now let's look at the mechanisms associated with extracorporeal shockwave, and in particular radial. So endothelial nitric oxide synthase. So that means that we're stimulating this process of angiogenesis and neogenesis. We're doing that through the vessel endothelial growth factor, proliferating cell anti-nuclear antigens, all these super cool things that if you think about those for a second, they increase blood supply. And the purpose for that is to facilitate, again, activity in tissue regeneration. And some really cool aspects of that include stem cell differentiation, especially in mesenchymal and adipose stem cell differentiation, which is fantastic. So that's all the really cool stuff. But here's the coolest thing, I think, is when we're looking at recalcitrant conditions, so things that aren't typically responding very, very well to other therapies or really a high level of chronicity. So if we think about the earlier studies and where we found shockwave to be most beneficial was actually in calcific tendinitis in the glenohumeral joint. Imaging, there it is, bang, bang, bang. We wailed on it with shockwave. We re-image, it's gone. We thought, oh, we must have blown it away, right? Because the history of shockwave comes from lithotripsy, which we literally did use that to blast away kidney stones. That's not what we do here. We are not destructive in our world, like, right? Even if you're doing ISTIM, you are disrupting the tissue matrix to stimulate what's going on here, which is actually something like apoptosis. And it actually stimulates the resorption of those materials that don't really belong there. I call it a slap in the face that says, hey, you're not supposed to be in the tendon. You get out of here. So that's, again, super cool. And then, hey, worst case scenarios, mechanoreceptor stimulation, which, we got a lot of other things that can do that. So when a lot of people say, well, it's about dealing with pain, don't just do that, right? Because what we're needing to do is match up with what's going on with why the patients actually came in to see us. And I'll talk about that here in a second. So the clinical implications here is it's really good for more of those chronic stages, reinvigorating and restarting something that's typically really recalcitrant. But what's different, in comparison to laser is that it's mechanical energy. It's a very high pressure that seems to stimulate the cellular activity a little bit different than laser, which is good. But if you think about that for a second, do I really want to do that during the acute stages? And the answer is you could, right? And there's ways to do that somewhat comfortably and be able to kind of move forward.